So I want to talk about percutaneous axillary balloon pump. I want to talk about the anatomy and access technique, exchange and closure, and the unique complications of axillary balloon pump. So why axillary access? Here are some ideas. The axillary artery is large. It is 5 to 8 millimeters, and it's more than 5 millimeters 97% of the time, enough to easily accommodate large sheath over 14 French. It's on average about 1 millimeter smaller than the femoral artery. Interestingly, it is much, much less often diseased than the iliofemoral arteries, and it has much often and much less calcium than the femoral artery. In general, the left axillary access has been preferred in most cardiac series. This is to avoid the balloon pump dwelling beneath the origins of the right and left common carotid arteries, which exposes the patient to a theoretical stroke risk. However, keep in mind that even though the axillary artery is rarely diseased or stenosed, the left subclavian artery may very well be stenosed in patients with PAD and CAD. So you need to rule out left subclavian artery stenosis when you want to do left axillary access, especially that the left subclavian stenosis is more common than the right. And the way you rule that out is at the very least by checking blood pressure in both arms. When is axillary access valuable? There are two instances where you need to consider it. One, femoral-iliac PAD or heavily calcified aortoiliac tortuosity. In this case, you need to consider axillary access even for short-term balloon pump or even Impella and TAVR. And the left axillary access is particularly favored for Impella CP and TAVR because it mimics kind of the femoral approach, the anatomy and the curvature of the femoral approach. A second instance where it's valuable is prolonged balloon pump support for advanced heart failure awaiting transplant or durable LVAD. Axillary balloon pump, as opposed to femoral balloon pump, allows ambulation. And there are multiple published series about using axillary balloon pump in patients awaiting transplant. And the medium axillary support used in those studies was 19 days in the Methodist series and 17 days in the Chicago series, and it's up to 40 days. Typically, when I say prolonged balloon pump support, I'm meaning more than 5 to 7 days. Another idea here, there is one series, one mostly surgical series that used the right axillary artery instead of the left or more than the left, and it showed that that was safe as well. And I will describe some advantages potentially of the right access in some instances. Now let's talk about the anatomy of the axillary artery. In order to successfully access the axillary artery, it is paramount to understand the anatomy. There are three anatomical ideas I want to highlight. The first idea is what is subclavian versus axillary artery. So the subclavian artery is inside the chest, whereas axillary artery is outside the chest. Axillary artery starts at the lateral border of the first rib, whereas the subclavian artery is inside that and inside the chest. So axillary access is inherently safer because it is outside the chest. So if you have a bleeding complication, it's more easy to control. It's more compressible against the chest wall. Another advantage of axillary versus subclavian is that the axillary is being outside the chest is visible via ultrasound. So axillary access can be done via ultrasound. Another thing is that the subclavian artery has an intimate relationship with the origin of the brachial plexus. So that's another disadvantage of trying to stick the subclavian artery, more risk of injuring the brachial plexus, whereas most of the axillary artery, except distally, has no relationship with the brachial plexus. Actually, even when we're talking about veins and venous access, nowadays, when we say subclavian venous line, we often mean axillary venous line. when we do ultrasound guided access, we're often accessing the axillary vein, not the subclavian vein. And even our EP colleagues, when they do a pacemaker, they aim for that lateral border of the first rib. So they are aiming really for the axillary vein. They try to hug with their needle the outer and superior border of that first rib. This is the first rib, this is the clavicle. They aim for that outer and superior border. They are aiming for the axillary vein, and they definitely try to stay out of the clavicle. So by today's standard, we try to access the axillary vessels, whether artery or veins. So the second big anatomical idea is, what is the relationship between the axillary artery versus the axillary vein? The axillary artery is more posterior to the vein, is deeper than the vein, and it's more superior to the vein. But the more distal you go into that axillary artery, the more superficial that axillary artery becomes, and it becomes as superficial as the axillary vein. You can basically split or set apart the axillary artery from the axillary vein as you go more distally in the mid to distal segment of the axillary artery. And if you abduct, open up the arm. This is unlike the subclavian artery, and that's another advantage of the axillary artery. The subclavian artery is posterior to the vein, and in order to access it, you have to go through the vein. Whereas the axillary artery is set apart from the vein. It is deeper, but it becomes as superficial around the mid and distal segments, particularly when you open up the arm. So you can stick it separately from the vein. You don't have to go through the vein, which of course you don't want to do. The third important anatomical idea of the axillary artery is its relationship with the brachial plexus. The proximal to mid axillary arteries do not overlap with the brachial plexus. The distal axillary artery, the so-called A3, while it's favorable in terms of its relationship with the axillary vein, is not favorable in terms of its overlap with the cords of the brachial plexus. So you can tell the ideal location for accessing the axillary artery is that mid segment. You don't want to go distally because of the brachial plexus. You don't want to go proximally because you're getting close to the subclavian artery and to the inside of the chest and to the origins of the brachial plexus. This is an illustration that shows the branches of the axillary artery as well as the segments of the axillary artery. So you need to know the three segments of the axillary artery. The first segment is from the lateral border of the first rib to the pectoralis minor. The second segment is behind the pectoralis minor, and the third segment starts from the lateral edge of the pectoralis minor all the way to the humerus head. You need to know two branches. There are a bunch of branches. You don't need to know those. Just know two branches, the two branches that are dangling down. Those two. The lateral thoracic branch and the subscapular branch. The lateral thoracic branch is that branch that goes down and hug the thoracic cavity and ribs. Those two arteries are important because when we do angiographic guidance access, we look for those two and we try to stick between them closer to the lateral thoracic artery. So we want to stick the second A2 segment of the axillary artery. And we aim by angio guidance to the segment between those two arteries closer to that one, to the lateral thoracic artery, which will get us into A2 and away from the brachial plexus. We want to avoid A3 because it overlaps with the brachial plexus, the cord of the brachial plexus. We want to avoid A1. Now, why do we want to avoid A1? Because in A1, it's very close to the subclavian artery, so you may end up accidentally sticking the subclavian artery and being inside the chest. 2, A1 has more overlap of the vein and the artery. Like I said, the more distal you go, the more you set apart the artery and the vein. 3, when you access A1, you have a sharp bend past it into the vertical portion of the subclavian artery. So you have more risk of kinks in the sheath. This is another illustration of the 3 segments of the axillary artery. Again, you try to stick between that lateral thoracic artery, this one, and the subscapular artery, definitely outside the chest and the first rib. Here is where we stick on the skin level. Some people think that when we stick the axillary artery, we're sticking in the axilla, behind the pectoral muscle. No, we're sticking the chest anteriorly, typically below that middle third of the clavicle, but definitely on the inside of the deltopectoral groove. So it's the anterior chest. In patients with ICD, we may end up having to stick more laterally, and we risk hitting the A3 segment and the brachial plexus. But we definitely try, even in ICD patients, to stay on the inside of that deltopectoral groove. This is another illustration. Again, we stick the anterior chest on the inside of the deltopectoral groove. And like I said, the axillary vessels are visible by ultrasound, except for the very thick patients. You can see them and stick via ultrasound. And this is an illustration of the axillary vessels. You see the axillary vein and artery. Again, the more distal you go, the more that artery becomes superficial, and at one point even more superficial than the vein. It is superior, but as superficial or more superficial distally, especially when you abduct the arm. So you can see the vessels here. You can see the pleura, that bright white line. And you can see in some cuts the first rib if you're proximal. Same, you see the pleura if you're proximal, close to A1. You may not see the pleura and rib as you go into A2 and A3, but you need to recognize it. If you're seeing it and you're sticking, one, try to go a little more laterally, or if you are sticking at this level, make sure you don't touch the pleura. This is another illustration, again, vein, artery, and you see here the pleural line. That's another advantage of axillary artery versus subclavian. You cannot see the subclavian by ultrasound because it is inside the chest. Now, how do you distinguish artery from vein? Artery is pulsatile, whereas the vein is not pulsatile and it's compressible. But those rules are not always true. In somebody with severe heart failure and ventricularized RA waveform, the vein may not be compressible and it may be pulsatile. So try to use Doppler, including spectral Doppler, to definitely differentiate artery versus vein. Size also helps. The vein is larger than the artery, typically, except in the hypovolemic or very hypovolemic patient. But in that case, the vein will be very collapsible spontaneously, and you will be able to identify it that way. In heart failure patient, typically the vein is larger than the artery. These are some other ultrasound images going from A1 to A3. See how the artery becomes progressively more superficial, and see how in A1 you can see the pleura, whereas in A2 and A3 you're far out of the chest and you don't see the pleura anymore. That's another advantage of sticking A2 rather than A1. You're definitely staying out of the chest and out of the risk of hitting the subclavian artery or hitting the lungs. And here is another image that is very lateral. If you go very laterally, you can even, if you're good, identify a nerve. So here you're not going to see a rib or pleura, but you can see nerve, and you want to steer away from this plane. The nerve would be like a thick white circle. Okay, this is from the brachial plexus. You need to avoid that area. You need to go more medially, not as medially as to see the pleura, not as laterally as to see the nerve. That said, in order to identify the A1 through A3 segments, it's not ultrasound that we use, it's the angiogram. That's why we use combined angiographic and ultrasound guidance. The angiogram will show us the chest cavity and the two dangling arteries and where to stick in the A2 segment. And the ultrasound will set apart the artery, vein, pleura, and sometimes you can see the first rib if you're close to A1. This is, for example, an image of a longitudinal ultrasound cut where you can see actually the rib, okay? And you have to make sure your needle doesn't go beyond that rib because now you're getting inside the chest. I want to indicate here that I frequently like to use longitudinal ultrasound rather than short axis transverse ultrasound to stick, especially if my lab has a small foot ultrasound. Why? Because especially in patients who have deep vessels, in thicker patients, it's easier to track the tip of the needle, the trajectory of the tip of the needle in longitudinal than short axis ultrasound. You may lose track of the tip of the needle in transverse cut, especially in those deep, thick patients. So longitudinal allows me to keep track of that tip and see where it's entering the vessel if it is getting too medial. This is how we position it, and this is how we should stick. We should stick in that lateral-medial plane at a shallow angle. And longitudinal allows me to stick in line with the artery at a shallow angle and still see my needle. You need about 30-degree angle in this orientation, lateral or medially, when you're doing axillary access. And it may be hard to track in a short axis, that shallow angle. If you do a short axis, as you're sticking, you may need to keep moving your ultrasound probe more and more medially if you lose track of the tip of the needle in order to keep track of it. So there is an advantage of that longitudinal ultrasound. Now, it's not usually feasible if you have an ICD, just because there is little room for the footprint of that ultrasound. This is an angiographic image that shows you the 3 segments of the axillary artery. So you see again here, this is the lateral thoracic artery hugging the thoracic cage. And this is a subscapular artery, the other dangling artery close to the humerus head. And you can see, of course, here the first rib and the lateral border of the first rib. So you try to stick between those two close to the lateral thoracic artery. We obtain this angiographic image, the angiographic roadmap guidance via another axis, whether femoral or more typically ipsilateral radial axis. So knowing all this information about anatomy and about ultrasound and angiography, how do I practically do axillary access? So I will explain to you all the steps of axillary access, the way I do it. So 1, you have to position the arm 45 to 90 degrees. Why? Opening the arm reduces arterial tortuosity, makes the artery more superficial, and as I said, it makes it as superficial as the vein and it splits it apart from the vein. If you have an ICD, I wouldn't do 90 degree. When you have an ICD, if you open up the arm 90 degree, the ICD will abut the clavicle and it will move more laterally and it will give you little room to stick A2. It's already hard to stick A2 in an ICD patient. You may end up having to go too laterally. So I try to keep it around 45 degree in ICD patients. We prep also the ipsilateral radial artery, and we do ipsilateral radial access with a 5 French slender sheath. If you already have a femoral balloon pump that you want to exchange for an axillary balloon pump, in that case, you don't need to do a radial access. You may remove the femoral balloon pump, exchange it for an 8 French femoral sheath, and use that for subclavian angiographic guidance. I will explain it a little more later on. So after getting our radial access, we do subclavian angiography transradially using a 4 or 5 French omniflush or pigtail catheter with 10 milliliter of contrast. It's better to use a cranial angle in this case to give you room to stick below the image detector. So remember, those are the first step. The first step is we position the patient, we do the radial access, and we do through the radial access the angiography. We haven't stuck yet, okay? We want to stick, and you don't want that image intensifier to be too close to the body. Remember, you want to stick in this area below the image intensifier. So it's nice to have the image intensifier a little bit higher than usual and to have it cranial, a little cranial. This way you have room to work while keeping roadmap imaging. So that's the reason I use cranial. Also, it's useful to have some cranial if you have an ICD to open the artery on top of the ICD. So it's not hidden by the ICD fluoroscopically. Once you do your angiography, use a smart mask imaging and place your ultrasound probe at the target area in A2. So we obtained this image by angiography. We did the smart mask. Then on top of this image, I see my lateral thoracic and I see my subscapular artery. I need to stick in this area, in between, but close to the lateral thoracic artery. But I want to stick with ultrasound, not with direct fluoro imaging. So here's what I do. I position either a hemostat or more typically the ultrasound probe in that area. So I position it and I take my hand off. I see if I position it appropriately. I keep moving it until I get to the right spot. Then I stick without live fluoro. So I use the fluoro to guide me, tell me where I should put my ultrasound probe and my hemostat, and I stick in that area without live fluoro. I don't like to do live fluoro for several reasons. One, I don't like to fluoro myself and fluoro my hands. Two, it's hard to do live fluoro and live ultrasound. It can become cumbersome. Fluoro can be deceiving because it's 2D images. You want the 3D images. You want the ultrasound value of showing you the vein and the pleura and possibly the ribs if you're too medial. So you want that combination. You use a fluoro to position your probe, then you stick under direct ultrasound. This is an illustration here of an angiogram in a patient with an ICD, and you can see the subscapular artery, and even with the ICD, you can still see here the lateral thoracic artery coming. You see that? It will come and it will hug the chest cavity. So you want to stick close to it. With an ICD, I end up having to stick somewhere here, a little more laterally than I wish. So I position my probe somewhere here. Then I stick under direct ultrasound guidance. Now, in patients who are very thick, in whom you're not able to get good ultrasound images, in those cases, then yes, I would use pure fluoro angio guidance to stick. So I would stick aiming for this artery under live fluoro. In those cases, I would also keep a wire in from the radial artery. I wouldn't just use the angio roadmap smart mask image. I would put a wire, and with my needle, I would aim toward that vessel, verified by both the wire and the smart mask imaging. So after I've identified my position, I stick under direct ultrasound guidance. I use the micropuncture, 4 French micropuncture system, a wire and needle. And this is the angle of the needle. So like I said, 30 degree in that lateral-medial plane. And I could use longitudinal ultrasound, usually not in patient with ICD, as there is no room for that. Now, you may, and it's not necessary, but you may, as you're sticking under ultrasound, at some point, as you're getting close to the artery, you may take your hand off and look under fluoro if your needle is aiming in the right direction. So you look, this is the needle. Is it aiming to the right area? Is it aiming to A2, just lateral to that lateral thoracic artery? You don't absolutely need to know that. But what you need to do is, once your artery is accessed and you advance a wire through it, then in that case, I would take my hand off, remove the probe or move the ultrasound probe, and look and see that my needle entry point and the wire are in the proper location, as it is here. You see the wire coming here, and the needle tip is in that A2, lateral to the lateral thoracic artery. So after you hit the artery and advance micropuncture wire, fluoro to see if it is A2. Then you place 4 French sheath in that left axillary A2 segment. Plus or minus, you may perform a sheath angiogram to confirm A2 location. You don't need to do that if clearly that image with the needle on the smart mask shows you that you're in the proper segment. Then through that 4 French sheath, you advance an 0.35-inch Impella super stiff wire. Then you progressively advance 6 French and 8 French balloon pump sheath. Then you steer through those 8 French sheath, you steer the Impella wire in the descending aorta. If it is not already there, if it had gone in the ascending aorta, you steer it in the descending aorta using your OmniFlush catheter or JR catheter. Then you exchange it for 300 centimeter or 18-inch wire or 0.25-inch Impella wire. Keep in mind the balloon pump catheter does not go over 0.35-inch wire. Then you advance your balloon pump in the descending aorta and you secure it in the descending aorta. This is another illustration showing you the lateral thoracic artery in a difficult case. You can always tell, even in a case with an ICD, you can always tell that origin of the lateral thoracic artery, especially if you do cranially. And when you position the balloon pump at the end of the case, you secure the outside of the balloon pump catheter, you secure it to the chest wall. You secure it to the chest wall, not to the arm. You secure it to the chest wall. This is an image. This is not an ideal stick. Like I said, you stick on the level of the skin, you stick on the anterior chest, typically below the middle third of the clavicle, and on the inside, always on the inside of the delta pectoral groove. Here we stuck, it is the anterior chest, but it's at the edge of the delta pectoral groove. Because of that big ICD, we had to stick more laterally than we wish, possibly at the junction of A2 and A3. And right axillary access may be advantageous in ICD patients who have an ICD on the left because there is less risk of sticking too laterally. So I explained the steps, which you need to know very well. Now, there are some modifications of those steps. In a patient who has already femoral balloon pump in place, you don't need to get radial access for angiographic guidance. You need to take that femoral balloon pump anyway. You may use that access for angiographic guidance, but it's not easy. So how do we do it? Keep in mind that the balloon pump catheter cannot take 0.35-inch wire. And keep in mind that you cannot just pull that balloon pump through the 8 French sheath, because now the balloon pump is flared and has wings, and it's not going to be shrunk enough to be pulled through that sheath unless it was placed in the last few hours. So how do we do that exchange? So one, you advance an 0.25-inch Impella wire or 0.18-inch stiff V18 wire long, 300 centimeters through the balloon pump arterial port deep in the aorta. Then you take both the sheath and the balloon pump while keeping that wire in. Then over that wire, you can directly advance an 8 French sheath in patients who are not very thick, especially if you have an 0.25-inch Impella wire, or alternatively, you can advance a 4 French dilator so that you can get an 0.35-inch wire, then advance a new 8 French sheath over the 0.35-inch wire. Now, keep in mind, even when you do this, the hole created by removing the balloon pump system is a little bigger than 8 French sheath because of the wing of that flared balloon coming out. May create tears in that arteriotomy, making it bigger than 8 French. So you may need to hold a few minutes of pressure around the new 8 French sheath, or if you keep oozing, you may need to put a 9 French or a 10 French sheath. But hopefully you try to keep it 8 French with manual pressure if needed around it for a few minutes. Then through that 8 French, you advance a JR4 transfemorally, and you use that for left subclavian angiography. Now, this exchange is important because another thing you need to do when you have femoral balloon pump is that you need to take it out regardless, whether you use it for angiographic guidance or not, it needs to be taken out. And it will be nice to take it out the way I described, to take it out and place an 8 French sheath, exchange it for an 8 French sheath so that you can do closure device at the end. Because you want to initiate anticoagulation. Once you start the axillary balloon pump, and you have an axillary sheath, you want to put the patient on anticoagulation to limit ischemic complications. So you want to be able to take that femoral sheath out with a closure device. So the way we do it, we exchange that from the beginning of the case, we exchange that balloon pump system for an 8 French sheath in the groin. Then we do our axillary access, axillary balloon using angiography from this femoral sheath as guidance. Then we take it out at the end using closure device. And you can close preferably with Perclose because it allows wire reaccess, or with 8 French angioseal. If you do angioseal, especially if there are concerns with oozing around the sheath, if there are concerns the hole is a little bigger than 8 French, place 2 wires in the artery and advance angioseal over one of them so you have the option of bailout if the first one does not succeed. Now, I want to describe some special complications of axillary balloon pump that you don't see as much with standard femoral balloon pump. One, a unique complication that we see commonly is balloon migration and prolapse into the ascending aorta, which is seen in up to 44% of patients based on that series from the Methodist Hospital. And that requires repositioning in the cath lab. So the axillary balloon pump may traverse a potentially more tortuous anatomical path compared to femoral balloon pump, which would increase the risk of kinky and migration. But more importantly, the axillary balloon pump pushes itself with each balloon inflation. Each time you inflate the balloon, you're creating a push on that catheter, which can, with time, push it all the way upstream and make it accordion into the ascending aorta. We call this complication accordion. This doesn't happen from a femoral access because the catheter is downstream of the balloon, so it's not getting pushed with each inflation. Another reason why this may happen is that, remember, femoral balloon pump patients, we make them flat and they are restricted to the bed. Whereas with axillary balloon pump, we can allow the patient to ambulate, and that increases the risk of migration. So those are some X-ray images. This is a case where the balloon pump has a prolapse into the ascending aorta. And I want to indicate here a couple of things. You may not get abnormal arterial waveform on the balloon pump or helium waveform early on. The kink may not be bad enough to cause abnormality in the waveform. So the only way to diagnose this is doing a chest and abdominal X-ray. The proximal marker may not have moved. It's the distal marker that moves. You see that the distance between those two markers has shrunk. That's your indicator. So look here. This is how it looks without me annotating it. You see this? And you see that. This is much higher. Well, what happened here, you can trace it in your brain. This is what's happening. Okay? Now, in more extreme cases, if you leave this alone, you will keep pushing and prolapsing this catheter in the ascending aorta. And you need to recognize this earlier. The earlier, the better. One group has identified that if that proximal marker is 5 centimeters above the carina instead of a couple of centimeters, you're already having this process early on, and you need to push it even at the bedside before you reach that stage where you need to go to the cath lab and straighten it with a wire under fluoro. Be careful as you're straightening this, as you're advancing a wire in the cath lab to straighten this, you may prolapse it in the LV. So you have to watch for that. And it may actually even prolapse spontaneously in the LV. So that could be a dangerous complication. At our institution, based on what Dr. Rosen has suggested, we have been keeping a wire in the balloon pump arterial lumen all the way into the iliac artery to stiffen the catheter and we keep it in throughout the stay of that balloon pump. We use the 0.25-inch balloon pump wire with a J-tip or 0.18-inch wire to stiffen the catheter and reduce the chance of prolapse in the ascending aorta. Evidently, we cannot use the arterial lumen for arterial monitoring anymore, so this patient needs to have a fiber optic balloon pump. Those patients are on heparin, so we feel safe keeping a wire in. One group has described the use of a long 8 French sheath instead of the short 8 French balloon pump sheath that comes with the kit. They describe the use of 8 French 24 centimeter arrow braided coiled sheath that is stiff, that is less likely to kink, and that prevents sucking of that balloon pump. It remains to be seen how safe that is in terms, does it increase the clot formation? But this is another idea that can be done. Another complication of axillary balloon pump is that it has a higher rate of malfunction requiring removal and exchange in 20 to 35% of the cases over a duration of support of median 19 days. Why malfunction? Because of severe kinks, whether from the trajectory or especially from that malpositioning into the ascending aorta. Another thing that can happen is a fracture of the arterial lumen or especially the helium gas lumen causing leaks, sometimes micro leaks. So that prolapse in the ascending aorta or the tortuous path of the balloon pump catheter can create fracture in the catheter and leaks. So you may get a leak where the balloon ruptures and you get blood in the gas lumen, but you may also get micro rupture and micro leaks where just that gas lumen communicates with the arterial lumen. And in that case, you will not see blood in your helium lumen on the outside. You're not going to see blood here, but you will see abnormality in the helium inflation waveform. And you will start getting alarm, and that will be your hint to that. Another special complication is balloon tip, that distal marker here, migrates into the visceral branches. This was seen in 3% in that Methodist series. That's unlike the femoral balloon pump, where the tip is not going to migrate into small branches. This one, the distal tip, can migrate into small abdominal branches, such as mesenteric or lumbar arteries, and it can cause ischemia or perforation and bleeding. Another idea not much talked about is that the fiber optic tip is here. So you're getting your waveform from the distal aorta on your balloon pump waveform on the console, not from the ascending aorta. So each time the balloon inflates, actually your fiber optic line may damp rather than augment. Now the ascending aorta is augmenting, but the descending aorta pressure may damp. So you may not get a proper augmentation waveform. This is particularly the case if the balloon pump is large compared to the aorta and is filling it very fully occluding it and opposed to it during each inflation. Frequently, that doesn't happen. You still get a decent augmentation waveform, but keep in mind, if you have a bad augmentation waveform, it may not be that there is a problem. It's just because you're monitoring the distal aorta. Now, I mentioned malfunction of the axillary balloon pump. Now, how to exchange that axillary balloon pump? So it's kind of the same way, the same steps that I explained for femoral balloon pump exchange, keeping in mind that the balloon pump lumen cannot take the standard 0.35-inch wire, and that you cannot just pull the unfolded balloon pump through the sheath. So the way we exchange, again, we advance 0.25-inch Amplatz wire, and you really need to try to have that wire if you're doing routinely axillary balloon pump, because it provides stiffness to both the balloon pump, so it makes it easier to take out, and it makes it easier to advance sheath over it without having to exchange for 0.35-inch wires. So you advance 0.25-inch Amplatz wire or 0.18-inch stiff V18 wire long through the balloon pump arterial port, and you take the whole system while keeping those 0.25 or 0.18-inch wire. Then over those, you advance the 8 French balloon pump sheath then you advance the balloon pump catheter over it. You may need to hold manual pressure around that new 8 French sheath, like I said, because when you take the whole system out, your hole may be a little bigger than 8 French. So you may need to hold good manual pressure for a few minutes around it and watch for hematoma. In case you cannot advance that 8 French sheath directly over the 0.25-inch wire, in that case, you need to advance a long 4 French dilator over your 0.25 or 18-inch wire, long dilator that lands in the descending aorta. Then you place 0.35-inch implants, then an 8 French sheath, then your balloon pump. Now, how do you exchange the axillary balloon pump for an axillary Impella CP? And I will describe whether you should do Impella CP percutaneously, and I suggest you shouldn't. But in infrequent cases where you need to exchange the axillary balloon pump to an axillary Impella CP, this is how you do it. It's kind of the same step. You advance 0.25-inch or 0.18-inch wire through the balloon pump arterial lumen. You remove the whole system while keeping the wires deep in the aorta. In that case, you definitely need to put a 0.35-inch wire. So you advance 4 French dilator over those wires to allow you to advance an 0.35 and exchange for an 0.35-inch stiff implants wire. Then you place the Impella dilators and sheath eventually. Then eventually the Impella itself. You cross the LV, then you place the Impella itself. Keep in mind, I describe how to exchange a malfunctioning axillary balloon pump. But sometimes the malfunction is so severe that this arterial lumen is fully fractured and separated that you cannot even advance a wire through it. In those cases, you may need to take the whole system out without exchange and without possibility of closure device. And I will explain how you can achieve hemostasis in those cases. Another thing you can do when the lumen is fully fractured and you cannot advance a wire through it, you may try to advance a wire next to the balloon pump catheter in that 8 French sheath. Because remember, the balloon pump balloon is not at this level, it's deep inside the aorta. So you may be able to advance an 0.14-inch wire next to the balloon catheter inside that sheath and into the axillary artery and deep in the aorta. This way you preserve your access and you can advance progressively more sheath and so on. Some groups have described a right axillary balloon pump. Right axillary may be advantageous in ICD patients, and they described a series of 21 patients with right axillary access. They did not have more stroke complications than left axillary balloon pump. And right axillary in those ICD patients was less risky in terms of sticking too laterally. Also, in that small series, there was numerically less balloon pump migration and catheter kink and fracture than left axillary balloon pump. Because for balloon pump, the curvature may be more favorable, less basically tortuosity from a right axis than from a left axis. It's a straighter, smoother line. So it's a possibility that right axillary may be advantageous for that. This is another series, a large series, 241 patients, in which right axillary access was used in 61%, left axillary in 39%. This was partly a surgical insertion series. And close to 30% of patients still needed balloon exchange because of migration or kinks or fracture. So we really need to know very much the steps of how to exchange that malfunctioning axillary balloon pump, because it will happen in close to 30% of patients. Another technical idea here is how to remove that axillary balloon pump and achieve hemostasis. Manual compression was recommended in the Houston Methodist 195 patient registry. Although the A2 segment of the axillary is not palpable in the anterior chest, it is compressible against the chest cavity. Keep in mind, again, the axillary artery is outside the chest. So if you push hard, you can compress that artery against the chest wall. So that was recommended in that series. Keep in mind, interesting that the same group, their original publication 2013 had recommended closure device, but their 2020 larger series, it was recommended to use manual compression. Another option is surgical cut down and removal during transplant surgery. So those patients who are awaiting transplant, when they do get their transplant, at the end of their transplant surgery, the surgeon may remove it via cut down and close via cut down. But this is my preferred method for closure. So I like manual compression, but a modified manual compression. Because if you fail manual compression, well, you may see an expanding hematoma in the neck. It may be difficult to bail yourself out in the midst of an ongoing hematoma and hemodynamic compromise. And hematoma is very risky in this area. Even though it's not as risky as a bleeding in the chest, it's risky because it can damage the brachial plexus and cords and cause irreversible nerve damage. So this is how I like to do it. So we like to take it out in the cath lab, preferably. You prep the radial access and you place a 6 French radial sheath, and you try to put a long 6 French 75 centimeter R2P sheath, those slick radial to peripheral sheath, 75 centimeter, that I make it land around the axillary artery. Then through that radial access, we can position 7 by 40 millimeter peripheral balloon, whether over 018 or 035 inch wire, across the arteriotomy distal to the vertebral artery. So we position that balloon, then we remove the balloon pump system, and we hold manual pressure for over 30 minutes. So we're doing hemostasis using 2 techniques. We're using the manual pressure, but we're also using balloon inflation. Typically, you take the balloon pump out while the peripheral balloon is ready to be inflated, and you immediately inflate the balloon as the balloon pump is out, and you're holding manual pressure. And the balloon is positioned at the arteriotomy, not proximal to it, at the arteriotomy. You don't want to position that balloon proximal to the arteriotomy. This is here, you can see, this is the balloon, and this is the sheath. So it's ready to go at the arteriotomy, not proximal. As you have seen, the axillary artery has a lot of branches and a lot of collateral. So if you inflate the balloon here, you may not achieve perfect hemostasis. You want to inflate it at the arteriotomy with this technique. So you remove the balloon pump system, you inflate that peripheral balloon, and you inflate it for about 10 minutes at a time while holding manual pressure. The beauty of having the 6 French radial sheath is that you don't just do peripheral balloon inflation, you can also do at the end peripheral angiography. So you verify that you've achieved hemostasis. And it's best to wait till the very end. So I do 10 minutes of inflation while holding 30 minutes of pressure. If things look clean clinically, you may wait till the end of manual pressure to verify that you don't have any bleeding using your angiography. The only issue with 6 French radial is that it does not allow advancing a cover stent in case of a catastrophic complication, in case you cannot seal the bleeding. That's why some operator and the Sky paper prefers the use of 7 French 90 centimeter sheath that you position in the left subclavian in order to have the option of covered stent. Here, this is from a JACC case reports. They inflated the balloon across the arteriotomy for 5 minutes along with manual pressure, but at the end of the 5 minutes, there was still a leak. So they inflated it another 10 minutes twice. But I prefer to do 10 minutes along with manual pressure and keep the manual pressure for 30 minutes. If things look clean clinically, at the end of that, you take your angiogram from a radial access. If there is a still leak, then you redo 10 minutes of pressure and manual pressure as well. Now, closure device. Can you do closure device for axillary access? The Sky document and the original Methodist publication suggest what we call post-close with angioseal or with per-close, but this is more risky. So here is how you do it. You do the exchange like I explained earlier. You basically exchange and position an 8 French sheath into that axillary artery. So you remove the axillary balloon pump system over 0.25 or 0.18-inch wire, position deep in the aorta, then you advance a new 8 French sheath over this wire if hemostasis is achieved around the new French. And that's the limiting step, because you may not achieve hemostasis. As I said, the flared balloon creates a hole potentially bigger than 8 French. But if hemostasis is achieved around the new 8 French, and the way you verify, you put that new 8 French and you do sheath angiogram, you see if there is a leak and bleeding around it. So if there is no leak around it, and again, after you do the exchange, hold pressure for a few minutes, then do a sheath angiogram to see whether there is a leak or not. If there is no leak around it, you close with perclose, which is preferred as you have wire reaccess, or angioseal. And even if you do angioseal, like I said, consider replacing 2 wires and placing angioseal over one of the wire, and the other one serves as bailout. Now, even if you do that, like you do with manual pressure, always get that radial sheath, or if you want femoral sheath, always get that second access and do balloon dilatation proximal to the arteriotomy. So you do your closure device, what we call a dry closure. You're doing it in a clean, non-bleeding setting. And it will serve as a bailout strategy. If your closure fails, there is no catastrophe here. You're having a balloon ready to control your bleeding. Now, here's an idea. When you're doing closure device, you don't want the balloon to be across the sheath and across the arteriotomy, because you want to deploy the closure device here. You want the closure device to get stuck into that balloon. So in that case, you inflate your balloon proximal to the arteriotomy. So in that case, you position your balloon, you inflate it proximal to the arteriotomy, then you remove the sheath and you deploy your closure device while the balloon is inflated. Now, if you fail clinically, or if you fail when you do the angiogram at the end, you see that there is still bleeding, then you can move your balloon around the bleeding area and inflate it at around 4 atmosphere at that bleeding area. Even if you're using closure, having this second access allows a final angiogram and a final repeat balloon angioplasty if needed, if closure didn't fully succeed. And like I said, bleeding doesn't usually cause hemothorax in those patients, but it can cause compressive hematoma in the neck and compressive hematoma of the brachial plexus that can cause irreversible nerve damage. Another tip regarding closure device, the hand maneuvers are slightly different than deploying them in the femoral artery, because the axillary artery has more elastic lamina and less muscular lamina than the femoral artery. So the tension required on the closure device anchoring is less. You don't want to do excessive tension in axillary versus femoral. With excessive tension, you can pull through the whole system, because again, that axillary artery doesn't have as much muscle. The final idea here, how about percutaneous axillary Impella CP? Here is my take on it. Impella CP may be placed percutaneously using the same steps as balloon pump, the same understanding of the anatomy, the same combination of ultrasound and angiographic guidance. But percutaneous Impella CP axillary placement is better reserved for short peri-PCI placement, where you do pre-close and you remove the Impella CP at the end of the case. So percutaneous Impella CP is reserved for peri-PCI support, short use for a few hours, not long-term use. If you plan to place axillary Impella for prolonged, indefinite duration shock support, or for pre-transplant LVAD in patients where balloon pump pre-transplant is not sufficient, then you need to do it surgically with cut down, graft placement, and eventual surgical removal, kind of like you do Impella 5.5. So you can do Impella CP percutaneously via the axillary artery, but for short-term use. For long-term use, it's better to do it surgically. For those reasons, doing it surgically, one, facilitates removal, because you cannot do just manual pressure with a large 13-14 French sheath. And the closure device, if you fail, it is more catastrophic with a 14 French sheath. 2, if you place that Impella CP for a prolonged duration, it's a larger catheter and a larger sheath in the axillary artery. So there is a higher chance of limb ischemia and higher chance of sheath and Impella thrombus formation. Based on a small series of indwelling Impella CP, there was a high thrombus formation over that sheath when it's done percutaneously with a long dwelling time in the axillary artery. Another idea is those patients, when you're putting Impella CP for prolonged support, they are sick patients and they may need upsizing to Impella 5.5, so might as well do that surgical access from the beginning. And this is how the surgical access is done. You put basically surgical cut down and you place a graft over that cut down into the axillary artery. The point of that graft is that, one, it allows you to position the sheath in the graft without having that sheath go into the axillary artery. So this limits limb ischemia. So that sheath, which is, let's say, repositioning sheath, 13 French or Impella 5.5 sheath, they stay here. They don't go in the artery. In the artery, you will have the Impella catheter, which is only 9 French. So that's one value of having a graft suited to the axillary artery. Another value of that graft is that it allows hemostasis. You tie it over the Impella catheter and the repositioning sheath, so much so that you prevent oozing around it. Now, let's say you have placed Impella CP percutaneously and you have left it in for several days, so you don't have a pre-close, which is, like I said, shouldn't be the usual scenario. But let's say you've done it in a prolonged shock or pre-permanent LVAD. How do you remove it? You can remove it using post-closure, using the same step that I described for transfemoral Impella, and I will describe them here again. And in that case, again, place a radial access, 75 centimeter R2P sheath or 90 centimeter 8 French femoral sheath or 7 French femoral sheath, and place a 6 to 7 millimeter balloon proximal to the arteriotomy for dry closure and a dry deployment of your closure device, also to allow you to do a final angiogram to confirm a proper closure. So if it is placed percutaneously for several days, you can do closure, although it's, again, very risky. And when you do it, definitely have a second access for dry closure and to confirm that you achieved a good result. And this is how we do post-close of Impella, as I describe it in the Impella talk. Basically, you have the 13 French repositioning sheath in the axillary artery. You cannot pull the Impella through it. The Impella motor is 14 French. So you cannot pull through it. So what you do, you advance an 0.35-inch wire through the side port. You advance it deeply into the aorta and exchange that wire. Then you pull the whole sheath and Impella out. Then over that wire, which is deep in the aorta, you advance a new 12 to 14 French sheath. Then in that 12 French sheath, you advance a second wire. So now you have 2 wires. Then you take out that 12 French sheath and you advance 8 French sheath over 1 wire and another either 6 French sheath or an 8 French angioseal or perclose over the other wire. The idea here is that you're trying to narrow down that 13 to 14 French hole into 2 smaller holes so that the perclose or the angioseal feet, which are designed for 8 French smaller hole, will be able to grab the edges of the narrowed down holes. Okay, so you advance 8 French sheath and 8 French perclose or angioseal. Then you deploy the perclose or angioseal where that 8 French is in place with its wire. Then after you close this area, now the hole is narrow for that sheath. Then over that wire 1, you deploy another perclose or angioseal. And keep in mind that if you're deploying perclose specifically over wire 2 while the sheath is over wire 1, make sure you put a dilator in that sheath, because the perclose may puncture that sheath accidentally and injure it and break it. So you put a dilator in it to prevent that. So this has a significant risk of failure, and that's why we have another access, radial or femoral, to help control bleeding complication if we don't achieve proper closure.